Hello, I'm Norman Swan. Welcome to this video conversation with Michael West, who's Professor of Organisational Psychology at Lancaster University in the UK. I've caught him on a trip to the UK where he's giving talks to health services, health service leaders in Victoria and elsewhere. Welcome to Australia, Michael.
Thank you, Norman.
Now, you didn't start in healthcare, did you? You started in the oil industry, is that right?
Actually, I started out, when I finished my PhD, I went and worked in a coal mine for a year
Right.
in South Wales. So
that was a limited career option.
And then after a year of that, I thought maybe academia might be a bit easier.
That's right. Although, teamwork keeps you alive in the coal mines.
Actually, it's a really insightful comment, because what really struck me when I first went underground was how your safety was dependent on the team that you were working in, and how safety was the top priority for everybody working underground. And it kind of spawned an interest in teamwork for me, which has carried on and really influenced my thinking about healthcare organisations as well.
Now, they say that in South Wales, in the mining valleys, the team is built around the pub and the local community, which is not necessarily what happens in a hospital. Well, you'd hope it wouldn't happen in a hospital. It might have done once, actually, but not now. Tell me how, we all talk about teams. We talk about them incessantly in healthcare. It is a team sport. The days of the lonesome cowboy are over, if they ever indeed should have existed. But how do teams evolve in the healthcare system as opposed to a mining village which has existed for hundreds of years?
Well, I guess the basic principle is that the nature of healthcare is so complex that one individual alone can't provide healthcare in an effective way. And you need people with different knowledge, skills and abilities to come together around a patient to provide high quality and continually improving care. And I think that's the really important point about team working is we don't build teams just to have groups of cohesive individuals. We build them because that's the best way we can fulfill the task of providing high quality care. But
they don't just happen. I did an interview once with the Qantas pilot who flew that A380. I don't know if you ever read the book, where he flew this A380 out of Singapore, an engine blew up and it should have crashed and it didn't, largely because of the team in the cockpit. And of course, on a Qantas jet and most airlines, you don't have a steady team. You don't have the same team every time. You've actually got to create it for every flight.
Yeah.
And they've got processes for doing that.
Yeah. So what's clear is that when you have a group of people who are not working together on a regular basis, that you need to have clear protocols and procedures that they can work with in order that they overcome the problems of not having familiarity with each other. So we know, for example, with cockpit crews, that most accidents happen on the first hop when they're working together because they haven't built up relationships. Usually in healthcare, we have more capacity to build relationships over time. But how we build a team seems to me it has to be around the task and a set of really clear objectives. All the work we've done on healthcare teams shows that healthcare teams are most effective when they have a limited number of clear, agreed objectives, and that they're clear about each other's roles, and really importantly, that they review regularly what they're doing, how they're going about it, and what they need to change.
So built around the task.
Yeah.
Isn't that the problem? That we're all task-focused and the patient's just somewhere in there as an invisible person, but we've got to do this, and there's the protocol to be followed. Oh, where's the patient gone? Yeah,
well, for me, the patient is the task. It's about providing high quality, continually improving and compassionate care to people. And to do that, we need people with the right skills and abilities to work together. I think once we lose the vision of the patient and the person as what the team's work is all about, we're in some trouble.
So there's not a person working in a health service in Australia or the UK who doesn't believe that they're working in a patient-centred system. They believe that it focuses around the patient. And we all know it doesn't, but they believe that it does. And I think that we've forgotten or never knew what it looks like when it is patient-centred. What does it look like?
When a team, I think, is focused on providing high quality care for patients, then they have compassion at the core of the way they interact with the patient. So they listen with fascination to the patient. They seek to understand what it is the patient's dealing with through a dialogue with the patient rather than through imposing an understanding. They empathize without being overwhelmed by the emotions or feelings or distress of the patient. And they're always asking the question, how can we serve, how can we help in the most effective way? And I think that those behaviours of attending, understanding, empathizing and helping also characterize the behaviours of team members in relation to each other, so that they model those behaviours in their interactions in an effective team also. So that you create a kind of climate within the team of compassion, both in terms of team members' interactions and the central focus on the patient.
Describe the behaviour then within a team that is compassionate within the team. I think we can all understand, well, perhaps we can understand what it means when you're talking to a patient. You know, you start from what they want, you look at their objectives and their goals, and you try and meet them with your care. Kind of got that.
Yeah.
What does it look like? I mean, is it all touchy-feely, and how are you going today, and you don't look so good today, and what does that compassion start to look like in a professional team, particularly if they're orthopedic surgeons?
Yeah, I think it starts with being present with each other. You know, one of the problems that we see in healthcare in terms of team working is that they're often so driven and they're so consumed with heavy workloads that they start to find it difficult to be present with each other and with patients, service users. And there's this phrase that Nancy Klein uses, listening with fascination. I think in really effective teams, team members are listening to each other with fascination. They're listening to each other's voices about the best way of delivering high quality care. And they're listening to patients with fascination. So I think that's the first and most important behavioural element.
How do you do that at 2 in the morning after a shift and you're completely knackered?
We can, I think, develop people's ability to learn to be present. And, you know, with all of the work, for example, around mindfulness in healthcare, that's proving very powerful in helping people to learn to be present with each other and with patients. So I think we can also help people to learn to listen with fascination to patients. Once we start to lose that, even if we're knackered at 2 in the morning, then we're in danger of making mistakes, and we're in danger of not showing compassion to patients, and with the potential consequences of that as well.
So almost, it's not quite paradoxically, but on the face of it, it seems paradoxical. You argue then that whilst you're the part of a patient-centred system is taking the temperature of staff.
We find incredibly powerful associations between the experience of staff and patient outcomes. So in England, we have a national staff survey for staff. We get 250,000 responses every year. We've been running it for 13 years. So we're able to look at the relationship between what staff experience in the workplace and patient outcomes, care quality, patient satisfaction, patient mortality. And we find that where staff report high work pressure, patients say there are too few nurses, they're not treated with respect and dignity. Where staff report poor health and well-being, high levels of stress, what we see subsequently is worse care quality, worse financial performance, and in the acute sector, higher levels of patient mortality, as well as poorer patient satisfaction. And indeed, the quality of team working is a really important predictor of some of those outcomes as well.
What then is the feature that translates that into action? I mean, a couple of weeks ago, I covered the story of that paediatric registrar, Bawa Garba, who was not only convicted of manslaughter for a multiple system failure, and she was the fall guy, fall girl, and then GMC insisted she be struck off for life. In a tertiary teaching hospital in a highly respected university in the UK, where clearly none of this was happening. The NHS spends, NHS spends all this money on staff surveys, and then presumably you're free to ignore it.
It's a tragic case.
So close the loop.
Yeah.
What closes the loop here?
Yeah, well, for me, I think that healthcare systems have at their core the value of compassion.
Or should have.
Should have. When our health services were created, they're meant, I think, to express national values of compassion. Our societies want to provide healthcare to all of those who need it. And the staff who work in these organisations also have a core work value of compassion. And the challenge for us is how we create cultures where staff can deliver high quality, compassionate care. And I think that means that the leadership of organisations, hugely powerful influence on culture, has to model compassion in the way they lead at every level, from national level leaders in the national organisations, statewide organisations, down to frontline leaders. Leaders who listen to their staff, who attend to them, who understand the challenges they face, who empathise with them and who take action to help them. So for me, that's a really important starting place. And in fact, in the English NHS, we've now got a new national framework for leadership development and improvement with compassionate and collective leadership at its core. So the aim is to spread compassionate leadership across the system. I think that's part of the solution to the problems of creating organisations that don't model the compassion which should be at the heart of our services.
What are the metrics?
Well,
apart from patient outcomes, what are the metrics to know that the process is delivering that compassionate collective leadership? Are there ways of measuring it?
Yeah, we've been looking at ways of measuring compassionate leadership amongst leaders in organisations. We've also been asking staff to complete questionnaires to look at their perceptions of the extent to which staff show patients compassion, staff are compassionate to each other.
So it's like a 360-degree
yeah,
assessment.
And leaders are compassionate. And, what comes out from that is the staff think they're pretty compassionate in how they treat patients. They think they're pretty compassionate with each other.
The managers are bastards.
But the leaders are not compassionate. There's a big gap. And actually, I think that gap is it's not just to do with the behaviour of individual leaders in provider organisations. It's also a consequence, I think, of our national systems. When we have oppressive regulatory and inspection regimes which don't model compassion in how they deal with the provider organisations, I think we create cultures that are characterised by fear and bullying and blame. And
it gets transmitted.
It gets transmitted. Absolutely, it gets transmitted, and out goes compassion.
So it starts at the top. But how do you, as a manager in a system, we'll come back to clinical leadership in a moment,
yeah,
but as a manager in the system where you are responsible for the organisation and you are not delivering on what the system has purchased from you, you've got waiting lists, you've got people over 4 hours in emergency, and you've got ramping of your ambulance system, and 3 nurses are off and the rosters haven't worked out. And you've got staff complaining and sort of, don't give me bloody compassion when you've delivered me this disaster.
Yeah, yeah.
How do you, and you want to be compassionate, but the system's not allowing you to.
Yeah. So we can carry on firefighting and desperately trying to manage these flames which grow higher every day. We can continue to load staff with more and more work and more demands and more complexity and see their stress levels rise. I think we have to go back to the basics and retrain our leaders to model compassion in the way they lead. But also I think we have to look at those organisations that have been successful in managing all of those challenges and delivering high quality care. And when we do that, what we learn from them is that there are 5 really key characteristics which are present in their cultures. The first is that they have a clear vision, which is not just a bunch of words on the website, but is what their leaders pay attention to and talk about and monitor to do with delivering high quality and compassionate care. And the second is that they have leadership that has identified what the key priorities are, 5 or 6 at every level, from the top team down to the frontline teams, rather than overwhelming people with so many priorities and initiatives that no one can see what's important and what's clear anymore. And third is they have great people management. They They have low levels of staff stress, they have high levels of staff engagement, they've retrained their leaders to adopt more positive, supportive styles, they're creating a positive culture, they're appreciating the contributions of staff, they're identifying the hot spots in the organisation where staff are overloaded and dealing with it and finding ways of managing those problems. And the last two are innovation. They're really good at identifying the key problems and developing solutions for those problems rather than just accepting them as part of the territory. And they're developing great team and inter-team working. So they're really putting investments into developing team leadership, team working, and inter-team working particularly, so that teams are working together across boundaries.
Isn't this just Management 101?
It is Management 101, absolutely it is. And the problem is that I think
people aren't doing Management 101.
People aren't. Well, it's a really interesting comment because, what I see in health services in comparison with other industries is we're not preparing leaders to lead in health services. So there's poor leadership or lack of leadership at many levels in health systems across countries, where you have people in interim posts, people acting up, people having their arms twisted to take on leadership positions, but not having the development that enables them to take on leadership roles with confidence and with skill. So I think that's the key issue that we need to address.
Can you be compassionate without autonomy?
Compassion and
in other words, can you achieve?
Yeah.
Just trips off the tongue. Compassionate collective leadership. Yeah. We haven't even talked about the collective bit yet, but we will.
Yeah.
But can you do that unless you feel? You psychologists call it, the locus of control. But essentially, that you've got some control over your destiny. You've got some freedom to make decisions. And you can act on things, which requires a lot of trust down the system. But can you do it without distributed autonomy?
I think distributed autonomy is fundamental in healthcare. We have in healthcare probably the most motivated, skilled workforce in the whole of industry. Why would we adopt hierarchical command and control directive approaches when we've got such a skilled, motivated workforce? And when we looked at...
Well, why is the minister's down asking questions about why there's a 2-hour wait in an ambulance ramp?
Yeah.
And you're under stress.
Yeah.
So the leaders themselves don't feel autonomous because they've got the department down their neck.
Absolutely. And when we looked at all of the research on high-performing healthcare organisations internationally and what characterised them, about the worst form of leadership was command and control. So I think this principle of creating autonomy for frontline teams is really hugely important in terms of culture. Actually, in the best performing organisations, we see that they have put staff in charge of service change. So rather than trying to manage service change and problem solve from the top down, they're listening to frontline staff and working with them and giving them the autonomy and, where necessary, the resources and the support to initiate the changes that need to be made. Actually, frontline staff often know what the problems are and what needs and what solutions.
And they're micro-innovating all the time without telling you.
Yeah, absolutely. Yeah. We hear frontline staff say, well, it's all these priorities, initiatives being loaded down on us. We just try to kind of ignore what's coming down and get on and do the job of providing high-quality care for patients and service users in the best possible way. And as you say, they're micro-innovating all the time.
There's a lot of talk in Australia and the UK about clinical engagement, engaging doctors, engaging nurses, and particularly getting doctors to lead. Yet if you look at most health systems, most managers were once a doctor or a nurse or a physio. So you actually do have clinical leaders, but somehow they change when they get into these management positions.
I think...
So we've kind of already got clinical engagement. I wonder where this all sits in the story.
I think there are two really important issues for me in relation to doctors and clinical leadership. One is, certainly the evidence we have in England, you cited the case of Dr. Bauer-Garber, is so tragic. But actually what we're seeing across the board amongst clinicians in England is doctors are under huge pressure. Their mental health is suffering because of the pressure they're under. that's unsustainable. We're losing doctors, whether it's GPs or hospital doctors or junior doctors. We're losing them in droves because we're creating working conditions which are simply intolerable for human beings. And I think the other problem is we're persuading and encouraging doctors, clinicians to take on leadership roles, but we're not giving them the knowledge and the skills and the abilities to take on those roles with confidence. So, what I think happens to people when they're asked to take...
So there's a training piece missing?
There's a training piece, there's a development piece, there's a support piece missing. And when I don't feel confident about leadership, I'm likely to revert to a command and control style. Confident leaders, I think, recognise that leadership is about facilitating others to do the job which they want to do of providing high quality, compassionate care.
Of course, that means trust, that's right, managing risk.
Yeah. And actually what we see is, it is fascinating, with compassionate leadership, people are much more likely to take risks within safe boundaries, whereas when people are afraid and not being managed by compassionate leaders but by directive leaders, they don't innovate because it's not safe to do so.
Because they don't know where the edges are.
Yeah, they don't know where the edges are. And also, where you have
Well, you think they would know in a command and control, but in fact they don't.
No, because you can't have control in such a complex environment, exactly. And when you have compassionate leadership, people feel, Amy Edmondson at Harvard calls it psychological safety in healthcare teams. So they'll speak up about concerns and errors and issues, and that creates the conditions for innovation, because if we can speak about the problems, we can start to address them.
It's fine talking about it. Implementing it is another matter.
Yeah.
We're running out of time, but just take me through. I'm walking into a disaster as a senior manager. Things are bad. It's a mid-staff. It's not quite mid-staff. We don't have too many. We don't think we've got too many mid-staffers in Australia, but we've got problem areas. And you're walking in, and you've got to remediate. What's the thinking process? What's the way you go about it?
So I came to the point in my work with my colleagues of saying, okay, we have a pretty good understanding of the kind of conditions that need to be in place in organisations, healthcare organisations, for them to be effective. Problem is, how do we get from where we are now to there in organisations that are struggling? And the answer we came to is it's about culture. If it's about culture, it's about the leadership. So we have to have the right leadership in place, not just now, but in the future too. So we've spent the last 3 years working with the regulator in NHS England, called NHS Improvement, developing a set of tools that organisations can use to assess their existing culture and leadership, and then plan for how they're going to get the culture and the leadership that they need in place, with leaders focused on the right areas that we've talked about, and having the skills and the values, compassion, a commitment to collective leadership and so on. And so we've designed a whole set of tools to enable organisations to do that. We've co-designed those tools with hospitals and mental health organisations. And the principles were, we wanted this material to be something that organisations could use for themselves. They wouldn't need consultants coming in. It would be open source. And really importantly, it would be evidence-based. So we're using all of the evidence about leadership development, about team working, about performance management, and using that evidence base rather than the fads and fashions, and trying to encourage organisations to create change teams across their organisations to work with those tools. So we've made all of that available open source. It's being used by many organisations in the United Kingdom, but also increasingly overseas. And it's a way of, I think, addressing fundamentally the issues that we need to address to bring about the kind of cultures we need in healthcare.
So finally, and I should have asked this right at the beginning, but I'm going to do it at the end. What does the word collective mean in your mind?
In my mind, it is moving away from the kind of command and control hierarchy to where everyone working in healthcare feels that they have leadership responsibility. If they see something that's not right, whether it's the way a surgeon's behaving or whatever, that they feel clear that they have leadership responsibility. Where there's shared leadership in teams, so everyone in the team knows that they will take on a leadership role when the task calls upon their particular expertise, for example, where leaders are working interdependently across boundaries together, prioritising care overall, not just their areas of responsibility, and where there are consistent approaches to leadership with, I think it's no good if in one department you've got a warm, supportive, compassionate leadership, and next door you've got some despotic, tyrannical individual. We have to have consistent approaches of authentic leadership, open and honest, humility, optimism, compassion and appreciation.
And when you've got a tyrannical leader and you're trying to change?
We have to address those behaviours, I think. The first step is...
Call them out.
And coaching those behaviours. If they continue, there comes a point, given that we know they're going to be damaging to patient care, where we can't accept that. So we have to, I think, deal with them in the short term, and in the long term, make sure that the kind of values we want in leadership and healthcare organisations are built into the DNA of all of our processes: performance management, appraisal, leadership development, and so on.
And coming back to the patient, full circle.
Yeah.
Are we asking the right questions of them in traditional patient experience surveys?
There are two things that we've been doing in our work. So we use the patient experience surveys, but also interviews with patients for them to tell us about the culture of the organisations that we're seeking to support to change. But the other evidence we have from across sectors, whether it's oil and gas or retail or wherever, is the more that the service user, the patient, the customer, is involved in the co-design of services or products, the more innovative and effective those organisations are.
So it's not just the team that designs change, they've got to include consumers in the
Absolutely.
design too.
Absolutely.
Michael, thank you.
Thank you.